So, hey everyone. Thanks for listening. We are here with Dr. Ben Thompson, head of palliative care at Prisma Health, the hospital system in South Carolina. Dr. Ben is also a graduate of UNC Chapel Hill School of Medicine and has been practicing in palliative care for his entire career. Here to share insights with our listeners. So, I guess, yeah, maybe just to kick it off. Ben, if you could give listeners an overview of yourself, how did you end up in the medical field and pursuing palliative care?
Well, thank you, Neil, for having me. I'm grateful just to sit down and chat with you about the career and about whatever else you want to know about. So I'm Ben Thompson. I got into medicine when I was a kid. I had some medical procedures done, and from that point on, I knew I always wanted to be a doctor. And I knew that the most important thing was helping people. Medicine, there are surgeries, there are procedures, there's medications, there's lots of different ways to help people. But throughout my career, I was drawn towards the people who I think required the most help, the people who are the sickest, and not only struggling with a physical illness, but dealing with complicated family dynamics, emotional burden of their chronic serious illness, with spiritual questions around their illness, and just being able to approach all of those things from a medical perspective was very important to me. And that led me to palliative care. So I started medical school at Chapel Hill in 2012. And when I finished, I decided to go into family medicine. Through the residency match service, I matched at the University of South Carolina, which is now Prisma Health. At that point, I knew I wanted to do palliative care. So I stayed here for our fellowship, and afterwards wanted to work in both the practice of palliative care, but also the education of palliative care. Medical education has always been really important to me, not only helping families, but helping those who will eventually be helping families themselves. So this opportunity allowed me to work in program leadership for the palliative care fellowship program. And I'm not the medical director of palliative care, but I am the medical director of the fellowship. So I'm in charge of picking 3 folks to train with me every year after they finish their residency. Part of that experience is also bringing resident doctors from family medicine, internal medicine, psychiatry, neurology, fellows from critical care, to spend time with me as well and see what we do. In addition to all of that postgraduate work, I do undergraduate medical education where I work closely with the second year medical students as part of their ethics curriculum, as well as I have a preceptorship. I actually just let 2 medical students go that had spent the morning with me today just to get to see what we do. So I think I'm sorry I'm talking so much. I wear a ton of hats, and it's a very exciting career that I've made for myself, where not only do I get to provide direct patient care, but I get to influence the direction of the philosophy of the palliative care team in South Carolina.
That's great. Congratulations on the career. And I guess to add to your comments about kind of education, I guess maybe if you could educate our listeners, many of whom might not be medical professionals or just kind of like lay people, what is palliative care? I know that sometimes people have some understanding or even potential misconceptions of hospice, palliative care, et cetera. And I think this would be a great forum for you to kind of help educate our listeners on what is the field of palliative care. What do you guys do? Maybe even if you could give examples of your day-to-day life and the types of people you help, when people should seek palliative care, how that differentiates from hospice care. Just kind of, yeah, feel free to give us a lay of the land of your field.
Absolutely. Palliative care is specialized medical care for any patient with a serious or life-limiting illness. Okay, it's different from hospice, which is typically an exclusive comfort-focused approach, knowing that a patient has months to live, and if their goal is to be at home. Palliative care is appropriate at any time when somebody has a serious illness. And in fact, there are studies showing that palliative care at the time of diagnosis of a serious illness like a metastatic lung cancer can improve survival. So patients with early palliative care interventions can live longer.
Wow.
They can get less aggressive care at the end of life, including fewer ICU stays or fewer life support machines within the month prior to their death. And it's compatible with life prolonging care as well. So even if I meet someone who says, "Hey, Ben, my oncologist told me to come over because I was diagnosed with lung cancer that had spread. They said that they can't cure it, but they can treat it. They can make me live longer with treatment." What I get to do, my joy in that case is to find out what's important to that patient. I had a patient in the last couple of years tell me that what's most important to me is that I'm able to walk my dog. I love walking my dog. I take them for a mile walk every day and twice a day. And if I couldn't do that, I wouldn't want to live anymore. So what happens is you get treatment, and sometimes the chemotherapy can make you feel so sick that you're unable to walk your dog. And it's not for me to say, "Oh, well, you said that walking your dog is the most important thing. You can't, so let's call hospice." It's reevaluating. We're in a really different place now. You're telling me that, you get chemo once a month, and then for 2 weeks afterwards, you can't walk your dog. Is that still most important to you? Is being able to sit on the couch with your dog and watch football, is that okay? So it's really tailoring the treatments to the patient. Our medical system is so subspecialized that sometimes we lose the patient in the collection of organs. My joy is bringing the humanity back, reminding the medical teams that I work with who the patient is inside of, the cancer that had spread, inside of the heart failure, inside of the lungs that aren't working well, inside of the failing kidneys. Like that there's someone in there who's had a life, who has experiences, which leads to the other large part of my job, which is supporting the family through that. Right?
Wow. Thanks. Yeah, no, thanks actually for sharing that. And that's really interesting and informative to many listeners who may not be familiar with the field, about like what kind of roles you play. And, sorry, I didn't mean to interrupt. Actually, on the family side, would love to learn about that too. Do you view that as part of the role, is not just the kind of patient support, but the family support? And, how do you kind of handle that and view that as part of your, job as palliative care doctor?
Sure. Yeah. I mean, outside of, the very small population of hermits who may live in the middle of the forest by themselves, caring for a patient is not just caring for the one person that's experiencing the illness. It's all of the folks that your patient is letting into their lives, whether it's family, whether it's a significant other. Maybe they don't have those, but they have a very loyal friend that comes to all their doctor's visits. And especially for me, dealing with folks who may have a life-limiting illness, the family are the people who remain afterwards. So while the patient may be the one who's experiencing pain and symptoms and may eventually die from their illness, making sure that the family is as prepared as possible to take care of them and, for the end of their life. I think you work as an entire unit, right? A patient's concern may be, well, I don't want to be a burden on my family. Or it may be, I don't want my family to see me like this, or I don't want to be at home, or I want to be at home. And my job isn't just to say, okay, but it's to say, well, tell me more about that. Is being at home important if it meant that your family was having to provide care for you? Would you rather be, if you don't have family, would you rather be in a long-term care facility for the end of your life? So navigating that with a family as well. In fact, In the next couple days, I have meetings with very large families who are all doing their best to take care of one person. And the goal of those meetings is just to get everybody on the same page about what's going on and what we can do to help.
Oh, great. No, that's great to hear. And I think, kind of dovetailing off that and thinking through kind of the way care is managed, I think a lot of the stuff that you're doing in your practice is kind of the family and the patient's interaction with the medical care system. What are things that you observe with kind of the other side of caregiving, which is kind of the home care, family care, private, outside care? What are some of the challenges you see your patients and their families dealing with in taking care of a loved one with serious illness, potential terminal illness, et cetera? And, where do you see kind of systemic problems or issues, that need to be addressed?
Yeah, most of my job occurs in the hospital, right? So I have an outpatient clinic as well, so I can see some patients, who are wearing pants as opposed to folks who are wearing hospital gowns. But a big question that comes up most often is, where do we go from here? We've stabilized our chronic illness, and do we go home for that? Do we go to a nursing home or assisted living or long-term care facility? And the question that always comes up is, well, who is going to help you out at home? Who's going to be the one providing care for you at home? Um, for us, what's most important for me as a doctor, what's most important is whatever the plan is, that it's safe for the patient and that it's oriented with what the patient's goals are, with what the patient wants. If the thing is, I want to go home and I know I may have months to live, but I want that time at home on my couch with my dog, then I want to do whatever I can to make that happen for the patient. So one service that we use often, and I didn't really distinguish it earlier, is hospice. Hospice is a service for folks who aren't pursuing aggressive care for a terminal illness and have a life expectancy of 6 months or less. It's a phenomenal program. It's government sponsored, and most commercial insurances also cover hospice care. But hospice itself is typically not enough to keep patients at home safely. They need either family support or they need to hire external caregivers. Something that I find often is that doctors haven't explained what hospice offers and what they don't offer. So one of the things that happens quite often is families will return home with hospice with a plan to keep their loved one there for comfort care, and they're surprised that there's not a nurse at bedside 24 hours a day. Like I mentioned, this is it's an insurance sponsored service, and you may get a nurse for a couple hours a week. You may have an aide for a couple hours a week, but the majority of personal care, overnight care, is the responsibility of the family.
Yeah, no,
So,
you're right. We see that, and that's definitely, and kind of to piggyback off that, what do you find, are families having a hard time, finding such care on their own? How are families managing to pay for care? And I guess, even from a consequence perspective, if they can't get the care, are there either consequences for the family having to do it or consequences for the patient not having someone around? Just kind of what are the things you see?
right. So if you're not able to provide the type of care that's necessary to keep someone at home on their own, there are several options. The first option is wave a magic wand and pay for around the clock care or pay for care that fills the gap. Wouldn't that be wonderful if all the patients could afford that? Now, even for a patient who's on hospice and has 6 months to live, 6 months at $30 an hour adds up very quickly. Um, in fact, there was an article published recently that I can send to you about the experience of one of the nurse practitioners on a palliative care team who kept their loved one at home because that was concordant with their goals. It lines up with what the patient wanted, but it ended up costing the family over $100,000 to do that.
Wow. Wow.
So if you have the money to do that and that lines up with your goals, or the patient has money saved up and that's important to them, then that's phenomenal. Uh, but if you're not able to provide safe care at home, then the alternative is returning to the hospital or potentially going straight to a nursing home. Typically, it's hard to get into a nursing home from the community, right? From not being in the hospital. So most often what happens is families, caregivers will bring the patient back to the emergency room and say, I really wanted to stay at home. He wanted to stay at home. That was what was most important to, my loved one. Unfortunately, we can't do it. We don't have the resources. And so they need to go back to the hospital until we can find them a safe discharge plan, which is likely a long-term care facility.
Wow. And I guess in the families you see, um, I remember some of the things that you've kind of mentioned offline have been, um, health outcomes. And I think that one of the things that you mentioned previously was this dual eligible study, where people are eligible for both
Sure.
Medicare and Medicaid and are able to get kind of supplemental caregiver support, resulting in much better outcomes. I think, yeah, could you kind of like speak about that some more, and just like populations where you see, the outcomes are much better for the family and the patient, and why you think that is, and how that might be used to inform building a solution for everyone?
Of course. I'm sorry, I'm scrolling. I have a couple articles pulled up that I wanted to mention, but the first one, and Neil, the one that you're mentioning, looked at patients with both Medicare and Medicaid and how their discharge from the hospital affected their rates of going back to the hospital for any reason. Whether it's I have a new infection, whether it's I have, and these are people who were discharged on hospice, uh, whether it's a new infection, whether it's symptoms that can't be controlled, whether we can't provide caregiver support. We know that Medicare will pay for hospice, Medicaid will pay for additional caregiver support. And they saw that the patients who had that second source of insurance that would provide for more caregiving received more intensive end-of-life care at their home, meaning more hands-on, more eyes-on. And those patients went back to the hospital significantly less often than patients who didn't have that extra support. So we know that having more care at home improves outcomes, assuming that the goal of the patient is to die at home, is very specifically in the hospice population.
Yeah.
And there's another study that I found that was mentioned on Geri Pal, which is another phenomenal podcast about this geriatrics palliative care space, looked at caregiver attributes and their risk of the risk to the patient of hospitalization based on those caregiver attributes. One of the things that they saw most often is that caregivers who had been working as caregivers for more than 4 years were able to keep patients at home much more successfully than folks who had been caregivers for fewer than 4 years. Okay. So when I think about my patients who may have a terminal illness, someone who's diagnosed with heart failure and may have 2 years to live, I know that the person who, their spouse, significant other, whoever's at home with them, they haven't been in that caregiver role that long, and they have a higher chance of returning to the hospital. Also, for those providing care more than 40 hours a week, 40 plus hours a week, there's a much higher chance of hospital readmission than those providing care for 20 hours a week. So the intensity, the frequency, and the duration of caregiving all lead to hospital readmission, meaning someone's at home, they've said they want to be at home, but based on these caregiver factors, they may have to come back to the hospital.
Wow. And I guess, further to that point, or kind of along those lines, like, what do you think can be done, to remedy the situation, at a system level. It seems like some of these are topics of, health disparity, and really health equity. Yeah, what do you think needs to be done?
Sure. The people who are best able to pay for care at home are the people that have the financial situation to pay for care at home. Among folks who aren't able to, now I would argue that the hospital has a financial incentive to help patients remain at home. And that's based on some hospital metrics that get measured. Um, but I don't know, Neil, that's a hard question. It's, from a system level, there's so many moving parts that coming up with a succinct answer for
Yes.
how do we how do we fix home health and home care it sounds like an impossible task. What I know is that about 80% of skilled nursing care occurs at home.
Wow.
I
Wow.
know that, families are struggling with this, and I know that the idea of providing, I keep using the phrase goal concordant, but meaning if someone says they want to be at home early in their disease course, that the family doing everything they can to keep them at home can be a real struggle.
Yeah.
Um, and, there's tons of papers that compare outcomes of people of color versus Caucasian folks and the care that they receive at the end of life, the communication with the health system. Um, but I think the longer runway patients and their families have to come up with a plan, I think the better chance they have of executing that plan successfully.
Yeah.
Um, our hospital has piloted a very innovative study on hospital at home. So for patients who are requiring more care than you could usually get at home, but maybe it's antibiotics for, twice a day. They can have a nurse come in and provide antibiotics twice a day through an IV for 6 weeks. And that keeps the patient at home. It keeps them in a familiar environment. It reduces their chance of getting delirium, which is confusion that occurs in the hospital when you're taking someone out of their familiar environment. And it does save money. It saves the entire system money. It saves the patient 6 weeks of hospital bills. It saves the hospital from having someone staying in a hospital room for 6 weeks. So I think that if there was a way to do that with the caregiving side as well, that would be a huge benefit to the entire system, the triad, right? The patient, the caregiver, and the medical community.
Yeah. Wow. No, thanks for elaborating on that. And I think that's really helpful for the listeners to understand, and really interesting even how the hospital at home, programs that you guys are piloting are working out, and that's things that we observe and see, in terms of like care gaps and ways to advance health equity, I think are in line with those, access to affordable care at home, and then hopefully over time, system-wide potential subsidization of that care, to improve outcomes and also just get the solution to more families, that need it. I guess to kind of shift out of the theoretical system perspective to even more of a personal perspective, I guess, yeah, would love to hear a personal story. Is there a direct story of care challenges that has impacted you recently or, throughout last several years, and, how that's led you to kind of see where there are gaps in the system and, spurred thinking about potential for solutions?
Well, I know we spoke about it last week as well. I think it's fair to talk about my grandmother who has a relatively advanced dementia, just had a fall and broke her hip. She and I just went to visit her, and her days and nights are mixed up. Her days and nights are mixed up. She's in a rehab, likely moving to a nursing home, and unfortunately, there's not enough staff there to have someone sitting with her 24 hours a day, or to continually reorient her to try to get her days and nights back on track. So she's sort of stuck in this limbo um, of sleeping during the day, being up and being agitated at night. And there's not a way to break out of it unless I was going to hire a caregiver for a couple days, 24 hours a day for a week, and see if gradually we can come up with a care plan along with the nursing home to get her back on track from a days and nights perspective. So it's frustrating, right? It's frustrating because I'm in South Carolina. My family in Ohio has done a phenomenal job taking care of them, but they're not medical. They have their own lives, and it's hard to expect anyone to spend that much time at the nursing home.
Yeah, no, thanks for sharing the story. And I think that's really helpful to illustrate that even despite you being in the field, you're experiencing, some of these challenges for, providing care for someone in your family, and especially at a distance. I think these are
Sure.
things many people are going through, and without even the industry knowledge, might even be struggling even more, so appreciate you sharing that. I think then on an aspirational level, I think if you could have kind of like a gigantic billboard anywhere, with anything on it, where, you can have the opportunity to get a message out to millions or billions of people, what would it say, and why, anywhere from a few words to even an entire paragraph.
Um, the most important thing is having a plan in place and communicating that plan to your loved ones. Um, Look at your state's Adult Health Care Consent Act to know who your spokesperson would be if you couldn't make your decisions. And if you're unhappy with that person, then fill out an advance directive saying who you would want to be your medical decision maker. If you're diagnosed with a serious illness or a progressive condition, or even something that seems more benign, like high blood pressure, which has a chance to lead to a serious condition like a heart attack or a stroke, starting to have some of those real conversations with loved ones well in advance. The earlier you can talk about these things with people, the better. I recommend talking about some of those things around the holidays, when or any time that your family tends to get together. So I think that having a plan in place. I always say I would tell you a joke about early palliative care, but nobody gets it. So getting early palliative care, uh, at the time of diagnosis of a serious illness can help your family. It can help you. It can help make sure that whatever happens in the future, there's a better chance that it's going to line up with what you want and what you don't want.
Yeah, thanks. That's really helpful advice, and something that I think many people would benefit from hearing. You know, any favorite books or kind of movies that you'd like to share with our listeners that have really greatly influenced your career or your life?
I have a ton. Um, there's a movie that was on Netflix called One Week. It's about a guy named Ben, so I was already very partial to this, who is diagnosed with a serious illness, I think an inoperable cancer. And he decides to take a motorcycle trip across Canada, across the Canadian highway, Route 1, starting in Toronto or Montreal and heading west. And it's an adventure story with a background of serious illness. So if you have an hour and a half, that's a great movie. Uh, there's some really good palliative care books. One's called Being Mortal by Atul Gawande. I think this is a book that can help bring the basics of palliative care to the masses. It's a very public facing book. Um, and one of my favorite books to recommend to people who may be interested in doing what I do in palliative care is called That Good Night: Life and Medicine in the 11th Hour. It's a book by a palliative care doctor named Sunita Puri, who details all the experiences in her personal life, both with her own family and through medical school and through her medical training that led her to a career in palliative care.
Oh, that's great. Thanks. Actually, really helpful recommendations. And, following up on that, what advice would you give to a, smart and driven young person who's about to enter the workforce, who wants to, change the world for the better?
Specifically the healthcare workforce or just the overall workforce? Actually,
Let's
I
say
think
healthcare, either both, but, let's say healthcare since we're talking about the topic, but could also be outside of health.
I tell people who want to go to medical school or to nursing school or to PA school, um, two things. One, I tell them get experience in the medical field. See if this is something that you'd want to pursue. And the other thing I tell them is to go wait tables. People forget that
Really?
medicine is a service industry. And if you spend a couple months waiting tables or doing any other customer facing job, I picked restaurant industry because I worked at a pizza place for a summer when I was in college. You can see how upset people can be if you're a minute late with their Diet Coke on a good day, right? You're out to dinner, you're having a good time. And to keep that in perspective, that in medicine, we end up meeting people at some of the worst times of their lives. You'll learn compassion, you'll learn grace, and you can also have a very tangential appreciation for how the service you provide influences the money that you receive.
Wow. That is really unique insight and something I wouldn't have expected. And I think many listeners will benefit from hearing that advice. And then I guess in closing, in an ideal world, if you could snap your fingers and, fulfill a dream of equitable access to care, for all that needed, what would that look like to you?
Um, Meeting people where they are, meeting our patients and families where they are, having an agreed upon plan for, oh, if you want to be at home, but you live with your son who works during the day. I'd like to find a way that we could safely fill that gap in care to allow the patient to remain at home. I think we have a ton of people who want to be part of this field. The numbers of folks applying to medical fields, nursing, pharmacy, PA, medical school itself, is continuing to increase. But that we need to harness that workforce, the people who may want to get experience and let them help keep our patients at home, right? That accomplishes a couple goals. That accomplishes us providing goal concordant care for patients and families, and it gives students and those interested in joining this field the opportunity to see if it's for them.
Yeah, great. No, that's a great answer. Really really appreciate that. And yeah, Ben, thank you so much. So much for
Confers on
taking the
me.
time to speak with our listeners and share your insights. We've just heard from Dr. Ben Thompson, head of the Palliative Care Fellowship Program at Prisma Health. Just like amazing insights, Ben, about both the field of palliative care and overall healthcare system and in-home care system, and kind of insights on patients and families and what they're going through with serious illness. So, thank you so much for taking the time to appear on our show. And yeah, I look forward to continuing the dialogue and working with you.
Pleasure's all mine. Anything I can do to help.
Great.